Hello and welcome. My name is Erin Moran, and I am the Clinic Partnership Manager here at the MAVEN Project. Thank you all for joining us today for appropriate use of stress testing with Dr. Robert Master. And you can go ahead and get started.
All right. So what I'm going to talk about is how to order the right test for the right patient when it comes to stress testing. And there's been a proliferation of different types of stress tests over the last couple of years. If you're not a cardiologist, this can be a little confusing. So the trick is to match the right patient to the right test, and whether, in fact, you should even order tests. So we'll go to the first slide, which is basically, if you'll, Aaron, yeah. So basically, I have nothing to disclose. Next one, next slide just talks about CME accreditation. Next slide. All right. So principles for choosing the right test for the right patients. And I think that the questions that the key number one is this test supposed to be diagnostic or prognostic, or in some cases, the patient has coronary disease, and the question is viability and whether or not this is just for reassurance. And I think whether you even do the test and how to put it in the right context requires what's called Bayesian analysis. And Bayesian analysis basically just means what's the pre-test likelihood of disease and what's the post-test likelihood of disease after you do the test. And I teach at Stanford, and one of the things I try to teach the students is, the medical students, is that a positive test does not mean you have disease, and a negative test does not mean you don't have disease. So let's take probably the three most common reasons people order a stress test. If someone has typical angina, their pretest likelihood of disease is 90%. With atypical chest pain, that is some features that suggest angina and some don't, it's about 50% ballpark. And non-cardiac chest pain is less than 10%. So I think one of the lessons is if someone has non-cardiac chest pain, they have localized stabbing pain, you can point a finger to it. It's not related to physical activity. Even a positive stress test doesn't mean the person has coronary disease. The statistical likelihood of that. So if someone has a positive stress test, a non-cardiac chest pain or asymptomatic, the chance that they have disease is maybe 20 or 25%, even with a positive stress test. Conversely, if someone has typical angina, where the pretest likelihood is 90%, and you have a negative test, that doesn't rule out that the person has coronary disease, and certainly not microvascular disease. So I would say, unless you're not concerned about the possibility of chasing a false positive test, that if someone has clearly non-cardiac chest pain, maybe you shouldn't even order a stress test on those patients. I would say that in general, I did not, unless they had a number of other risk factors and I wanted to do the stress test for other reasons. But generally speaking, if the person with non-cardiac chest pain has a positive test, they still are unlikely to have disease, but then you're committed to another more expensive and possibly more invasive test. The next question, other than prognostic versus diagnostic, is can the patient ambulate? What is the thing that limits the patient's exercise? Do they have an orthopedic problem, such as a knee or an ankle problem? Do they have peripheral vascular disease and have claudication? Do they have a respiratory problem, such as COPD or exercise-induced asthma? And with exercise-induced asthma, I just have people take their inhaler before they start the stress test. Are they frail? So depending on what the problem is, and if you're, just because someone is, for example, out of shape, I might put them on a different protocol other than the typical Bruce protocol that we'll be talking about in a minute. I may go a lot slower. And I might start at a slower pace and a lower incline, but it doesn't mean we're not going to hit their target heart rate and get a diagnostic test. But in order for there to be a diagnostic test, you have to have chronotropic competence, meaning that you have to get up to 85% of the age predicted maximum heart rate, and we're going to get back to that in a minute. So I would have people hold their calcium blockers and beta blockers typically the morning of the tests, not necessarily 2 days. So, the longer you hold, for example, beta blocker, the more likely you are to get into what's called the beta blocker rebound. But typically just holding the morning dose of the beta blocker, the calcium blocker is sufficient. Exercise, the question then becomes, well, should you exercise people at all? With all the pharmacological stress testing that we have available now, why even bother? Well, exercise adds, as we'll talk about, additional diagnostic and prognostic information so that if someone can exercise, I try to exercise them. If they can't exercise and I think it's dangerous, then we'll do or have some other contraindication, I'll do pharmacological stress testing. So what are some of the other questions? Well, certainly in the MAVEN patient population, what's the cost of the test? Obviously, a exercise treadmill is the least expensive and should be your default option. There should be a specific reason to order imaging or use a pharmacological agent, which adds cost. Where is the expertise locally? For example, are people better at reading stress echoes or stress nuclear studies? Is the patient morbidly obese? That might be a reason not to do a stress echo. Which modalities are available? So in some cases, some tests are just not available to your patient population. And the other thing that people, I think, are paying a lot more attention to is radiation exposure. So when you do a chest X-ray, your exposure is 0.04 millisieverts. So that's a measure of radiation. To give you an idea, a chest CT is 8. A nuclear stress test is 12. With technetium, with thallium, it's 12. With a coronary angiogram, it's 5 to 16. So basically, when you do a nuclear stress test, that's equivalent to 1,000 chest X-rays. So for example, in a young woman who still has her breast and hasn't had breast cancer, I would be very reluctant to order a nuclear test, particularly as the first line of testing. Next slide. So you'll hear a lot about MET, so I thought I would just cover that. So a MET is the metabolic equivalence of task. And one MET is basically how much oxygen a 70-kilogram 40-year-old male uses, which is 3.5 milliliters per minute per kilogram. And that's not all that important, except for the fact that you should know that, stage 1 of a Bruce protocol is about 5, stage 2 is 7 METs, stage 3 is 9 METs, and stage 4 is 12 METs. And why is this important? Well, it gives you some idea, if you're talking to a patient about what they do on a daily basis, you can translate that into METs. So for example, if someone can walk 2 miles an hour, that means that they're able to do about 2.8 METs. So they might have a little trouble doing the first, getting out of the first level of a Bruce protocol. So maybe I would take that person and put them on some other protocol. If they can go 3 miles an hour, that's 3.3 METs, still not very much. 5 METs is 4 miles an hour. If you walk uphill, that's 3 METs. If you vacuum, 3.3. Gardening is 4. Mowing is 5.5. So you can see, you can kind of get an idea of what people are capable of. The next thing is the target heart rate. And when we do an exercise, we're trying to get the patient up to 85% of their age predicted maximum heart rate. And that equation is your age subtracted from 220. So for a 40-year-old person, you're shooting for a heart rate of 180. If they don't hit 180, it's non-diagnostic. It's a submaximal test. And, if the test is positive, fine. But if it's negative, it doesn't mean anything. So, you want to get a test the person to get their heart rate up. And there can be both intrinsic and extrinsic reasons for this. Intrinsically, someone may not be able to get their heart rate up because they have chronotropic incompetence, which some patients have, or it could be they have disease of the proximal right coronary artery. If it's extrinsic, it could be due to drugs like calcium blockers and beta blockers. So, I think you want to, a negative test if it's submaximal is not very helpful. So low exercise capacity doesn't preclude a diagnostic test, but may result in use of a less aggressive protocol. So like I say, someone tells you they do very little, they're very not in very good shape. We will typically put them on a non-Bruce protocol. That doesn't in any way influence your ability to get a diagnostic test. And you just want to make sure that the person can safely exercise. So if someone tells you that they pass out a lot, or they're very unsteady, and their knee all of a sudden gives out unpredictably, and there's a risk of a fall, then that's a reason not to do exercise. Next slide. So what tests are you asking? And this is sensitivity and specificity. So you want your test to be sensitive. That is, what percentage of people who have disease and have are picked up with a positive test, versus specificity. What percentage of those with a negative test do not have disease? What you don't want to do if you're doing a diagnostic test, you'd like the sensitivity ideally to be 100% so that you don't miss people who have disease. Prognosis is different than disease detection and has more to do with decision making, such as, does this patient need invasive studies and do they need revascularization? So a negative test, which may not exclude a diagnosis, and a low-risk positive test, which may not confirm a diagnosis, may guide a conservative clinical pathway. So for example, if someone has a positive test or negative test and they can do 15 minutes of exercise, it's unlikely that you're going to improve that by putting in a stent or a bypass. Next slide. So this is a busy slide. We'll focus on number 3, which is the most common thing. So someone who has some features of typical angina, intermediate pretest probability of disease. So they have some features of angina, some features that are not, and the EKG is interpretable and the person's able to exercise. And you can see A means that's appropriate. So a regular exercise stress test would be the number one thing. Yes, you can do a radionuclide stress or stress echo, but from a cost effectiveness standpoint, a regular stress test is fine. Next slide. So we're going to talk about first just plain old stress testing without any imaging. Basically what we're looking to see is, can we reproduce the patient's chest pain with exercise? And obviously to do that, the person has to be able to exercise. And what you're looking for is that the person's resting EKG is normal, but with exercise and or chest pain, they develop 1 millimeter of horizontal or downsloping ST segment depression. And you can see here that the sensitivity and specificity are fair, roughly 70% for both. Now, what are the things that let you know ahead of time that this is worthless? One is a left bundle, because you're looking for normal EKG that becomes abnormal. So a left bundle branch, pre-excitation, otherwise known as a WPW, left ventricular hypertrophy, with or without ST changes, greater than 1 millimeter of resting ST depression, pace rhythm, all those things preclude a diagnostic test because the resting EKG is abnormal. So anyone that you're considering just doing a regular plain old stress test needs a resting EKG. The absolute contraindications to exercise, I think, are pretty intuitive. You don't want someone with a recent myocardial infarction or unstable angina, an uncontrolled arrhythmia, or severe symptomatic aortic stenosis. I used to use stress testing in people who had asymptomatic, but what I felt were severe aortic stenosis, to see there are two types of people. There are people who exercise and have symptoms and stop, and there are other people who just avoid. They know, not to do that level of physical activity. So they tell you they're asymptomatic, but that's because they don't do anything and they avoid physical activity. So sometimes for asymptomatic disease, such as severe aortic stenosis, a carefully monitored stress test is very helpful in eliciting symptoms and a abnormal blood pressure response, because normally the blood pressure with exercise should increase. Someone with symptomatic heart failure, acute pulmonary embolus, obviously myocarditis, pericarditis, acute aortic dissection, do not do stress testing. Next slide. So this is an introduction to the Duke treadmill score, which has to do with prognosis, not diagnosis, but prognosis. And what they looked at was the exercise time is the Duke treadmill score minus 5 times the ST segment depression. So the number of millimeters of ST depression minus 4 times whether the person has chest pain, and chest pain is 1 if it's non-limiting and 2 if it's limiting. And so you can certainly see that the more negative the number, the higher the risk, more ST depression and more chest pain and a lower exercise time. So if you look at the right-hand side of this slide, which looks at 4-year prognosis, whether people are inpatients or outpatients, you look at high-risk people and you look at the risk of death. In high-risk patients, it means almost 30% of the people have died if they're inpatient and 20% as an outpatient in 4 years. That's a pretty high number. On the other hand, low-risk people, after 4 years, the risk of death is only 1 or 2%. Next slide. So once again, exercise capacity is a very powerful predictor, and it's one of the reasons that I like to exercise people, if possible, if they're able to do it. And on the left-hand slide, you see a series of curves, and on the y-axis, you see mortality in both of these. And on the left-hand side, you can see that the people who have the poorest exercise tolerance, the top line, have the highest mortality. People with the best exercise tolerance, the solid black line, have the lowest mortality. On the right-hand side, it looks at men versus women, but once again, same idea. The people who are in the highest quartile of exercise had the best prognosis, and the people who had the worst exercise tolerance had the worst prognosis. Next slide. So when do we do pharmacological stress testing? And it's interesting, about 50% of nuclear stress tests are non-exercise. And there are several reasons for this. One is these people have not achieved the target heart rate, and maybe because they didn't stop the beta blocker or calcium blocker as instructed, or they're limited by something else, orthopedic or non-cardiac restrictions. So you can imagine if someone has a bad knee, they may be limited by that rather than by their heart. In which case, exercising them will not get you to a diagnostic test. Similarly, if the person has an abnormal baseline EKG, such as a left bundle or a paced rhythm. So in those people, you're going to do pharmacological stress testing. Now, interestingly, pharmacological stress testing increases coronary flow greater than that achieved with exercise, but it doesn't really change the sensitivity of the test. Next slide. Next slide after this. So we're going to talk about stress echo. And when we do stress echo, typically you do the exercise, the patient is limited, and then you have them lie down, and then you do an echocardiogram, and you basically look at different wall segments. And in this case, you're looking at apical, mid, and basal in the short axis view. And the apical has 4 segments. There are 6 segments in the mid-left ventricle, short axis, and there are 8 in the basal segment. And then we also look at the parasternal long axis view and look at those walls. Next slide. So that's how we do it. And this is a typical stress echo that you're seeing with an apical 4-chamber view on the top with rest and stress, and then below that is an apical 2-chamber view, rest and stress. And one of the things you see is that up in the apex, this apex is bigger than this apex, and you see that in both of these. So what's the advantage of a stress echo? Well, one is it doesn't take any longer than a regular stress test. They don't have to go anywhere. There's no radiation. Because you're doing echo, you can see other abnormalities such as the pulmonary pressures and valves, in addition to wall motion abnormality. The sensitivity and the specificity is, as you can see, higher than just an EKG-based stress test. We were saying that the sensitivity and specificity there was 70%, and this is 80+%. And then if you do dobutamine, you can also tell whether a hypokinetic segment, a segment that's not contracting normally, is contracting, is viable. That is it just hypokinetic because it's ischemic at rest, or is it just scar tissue? Next slide. So if you look at prognosis and risk prediction with a stress echo, the more wall segments that are involved, the worse the prognosis. So on the left-hand side, you can see the cardiac event rate % per year. And on the x-axis, this is the number of wall segments that are involved. Similarly, on the right-hand side, you can see prognosis. And the people who have the worst prognosis are the people who have the greatest number of wall segments, which makes sense that basically what we're saying is the more of the heart that's not getting an adequate blood supply, the worse the prognosis. So that's intuitive, but it shows you how the stress echo not only tells does someone have a ischemia, but is how much of the heart muscle is ischemic. Next slide. So what about nuclear study? And this is helpful both in terms of viability and perfusion. Perfusion is basically, is there normal blood flow or is there ischemia? Next slide. So this is a nuclear study, and this is what we're looking at is we're tomographically slicing the heart from on the top 2 rows, apex to base, and the next 2 rows a little bit higher. So you're going from the apex of the heart up to the base as you cut from the bottom to the top, and then you keep it. The next segment would be right here, and then this is rest versus exercise. This is the sagittal view, and you're looking at rest and exercise, and then this is going from inferior to anterior, going from the bottom of the heart to the top of the heart. And so you can see here, it looks like a bunch of Cheerios, and you can see where in the mitral valve plane, there's a defect, and that's normal. In this sagittal view, the aortic and mitral valve planes make this look like a reverse U, and then this is a U that's kind of upside down. Next slide. And those two, basically, they should look the same. And once again, the sensitivity and specificity are higher than that of a routine EKG in the range of 80%. And pharmacologically, it's about the same. And it tells you not just the location of a perfusion defect, but the severity. You can use pharmacological testing to vasodilate the arteries. And this is particularly helpful in patients who have a baseline left bundle or pacemakers. And then basically you can do a viability evaluation and see, because the heart muscle has to be viable to uptake the isotope. If it's scar tissue will never take up the isotope. Next slide. So once again, very similar to the stress echo, the perfusion defect correlates with prognosis. And this is, here they're using what's called the sum stress score, which is the combination of stress, which is ischemia, and rest, which is infarct. So it makes sense that if someone has a lot of ischemic myocardium and a big infarct, they're not going to do well. And you can see here that in terms of infarct, which is in green, and cardiac death, that if your sum stress score is high, your mortality is and risk of a heart attack is much greater than if their sum stress score is normal. Next slide. So high-risk findings on a SPECT is perfusion size and severity. So summed stress score, SSS, the summed rest score is ischemia, and some difference refers to the difference between those two. If you see transient LV dilatation, that's a high-risk finding. That means the left ventricle dilates with stress. Increased lung to heart ratio. So if you're having trouble seeing the image of increased lung intake, basically what that means is the person has gone into mild pulmonary edema, mild heart failure with exercise, and you only see that with multivessel disease typically, or left main disease. If you see uptake in the right ventricle, that's typically something that you see with right ventricular ischemia and decreased left ventricular post-stress left ventricular function decreasing. So, you can actually measure left ventricular function now from a nuclear study. And if the ejection fraction is down after exercise compared to baseline, so, someone has a normal resting ejection fraction, but post-stress, it's decreased, it again indicates the fact that this is a case of multivessel or left main disease. Next slide. So very simply, low risk myocardial perfusion scan versus a moderately severe one, much higher risk. Next slide. And if you incorporate the Duke treadmill score plus the thallium, so if you exercise people and then do a nuclear study and you combine that information, if people have this is looking at a low, intermediate, and high Duke treadmill score, and then a normal, intermediate, and high risk thallium. If people have a high Duke treadmill score and their thallium is very abnormal, then they have the worst prognosis, not, fairly intuitively. Next slide. Next slide. Oh, we missed one. Next slide. Yeah. So this is the summary. So what are the take-home points? Stress testing provides important diagnostic and prognostic information in patients who have symptoms suggestive of obstructive coronary disease, such as angina. Cardiac stress testing is indicated for diagnosis. Cardiac stress testing in asymptomatic patients is rarely indicated. It's not it's not something that typically you would do with rare exceptions. One of the exceptions might be, for example, let's say someone has a very high calcium score. Normally, a calcium score is 0. A high calcium score indicates dystrophic calcification in the coronaries, indicating inflammation. And it doesn't necessarily mean you have obstructive disease, but if someone has a high calcium score, the risk of obstructive disease is greater. So if someone had a very high calcium score, you might want to do a thallium scan just to make sure they don't have obstructive ischemia. In patients who can exercise, a symptom-limited stress test is the way to go, and certainly have them on a treadmill. For people who either can't do exercise or have a non-diagnostic EKG, a pharmacological stress test. We talked a little bit about calcium scoring. That's not really part of this, but it's not really indicated, I don't think, diagnostically as a test for risk stratification, other than in people who have a high cholesterol. And the question is, should that and they have a family history, should that person have stress testing? That might be one reason. Like I say, a high calcium score might be a reason to do some type of stress testing on someone who's asymptomatic. But the optimal cardiac testing modality should take into account the person's symptoms, which has to do with their pretest likelihood of disease, and the clinical scenario goes along with that. The technical aspects of the test, do you want to radiate this young person or not? What things are available, the collateral information, that is prognosis. So those are all the things that get into which test to order. So I'll just leave things open to any questions.
Thank you so much, Dr. Master. Anyone who has questions, please feel free to submit them into the Q&A, or you can unmute yourself or raise your hand and I will unmute you. We still have about half an hour for the call, so please feel free to raise your hand or submit a question.
I wanted to make sure there was enough time for questions. I realized I was probably going a little fast over some of those things. But the thing to ask yourself when you're seeing a patient is, number one, why am I doing the test? Is it for diagnostic or prognosis? Can they exercise, and what's their resting EKG? And I think those, and then, what things are available? What testing is available locally? Is there any questions? Or I can't see, so.
I'm not seeing any questions or comments yet. Do we have any comments? I guess you just really covered everything, Dr. Master. We'll give it.
I covered a lot, probably too much, but I think it's gotten very confusing about, if you're actually ordering the test as opposed to sending someone to a cardiologist. It's often hard to know as a non-cardiologist, what's the best test to do here.
Mm-hmm.
And it's not necessarily the most expensive tests. Like I say, you have to put it into a clinical context. One of the things is taking a good history. And if it's pretty clear to you from the history, you have a 20-ish-year-old person with non-cardiac chest pain, don't do a treadmill just to reassure them. I think that is, like I say, that is a habit that people do reflexively, and is not a good idea, because even a positive test doesn't necessarily mean disease.
So we do have a question now. What you just stated, the provider said, that was actually my question. Do you prefer to have the patient referred to you so you could decide the test, or do you prefer primary care order the test first?
Well, I think it depends on what question you're asking. So if let's say you're seeing the patient, you're in primary care, and you're suspicious someone has coronary disease, it all depends on what you're going to do with that information and how comfortable you feel handling the results. If you feel perfectly comfortable based on the clinical history with getting a test result, whatever it is, and say, oh, I can treat this, person has a low risk test, and I'm perfectly capable of putting this person on medical therapy and optimizing them, that's fine. On the other hand, if you're not sure what kind of a test to order, and you're not sure what you would do with the results of the test, or you think someone is unstable, so there's a lot of things that go into whether or not. I certainly, in my practice, had a huge number of patients who were just referred for the test, and a huge number who were referred to me who I decided to order a particular test. So I don't have a good answer for that, because it really depends on the patient and the doctor. Oh, good. I see some questions popping up here. So let me just see. I have one. Sorry.
That was one. We just did that one.
Okay.
Anything else? And again, remember, you can raise your hand and I can unmute you so you can speak directly with Dr. Master. Going once, going twice.
Well, thank you for your time. Hopefully this was helpful. And I think that with the information you have, you're much better armed to order the right test for the right patient. So thank you.
Definitely. Thank you, Dr. Master. And you're getting some nice comments in the chat. Thank you. This is very helpful.
Great. All right. Bye-bye.